Right. I think.
Press the button.
Cool. Broadcast or I don't know. It's a shame I don't have a. No. Needed a goat. Yes. I guess I'll just start. Do I just start? I don't know what's in there. Start? Yep. Okay. I will just get going then. So there's lots of familiar faces here, but for those of you who don't know me, my name's Nathaniel Hawkins, or Nat, or Nate in Canada, and I'm interested in heart function and EP and health systems, quality improvement, and this is just a sort of collection of thoughts and some insights as to what we're doing in the heart failure realm locally and regionally, and you'll see a large swathe of people from cardiac services here, so hopefully provincially, so this is like a pitch for to the directors of all things important about where we're going with heart failure. I have no disclosures relevant to this, so I think we want to talk about heart failure in terms of, what it means to the health system and complexity. Look at some of the quality improvement initiatives around the world that we can learn from, and look at how data is used in those systems as well. And then hopefully I'll try and convince you that I suspect the future is going to be largely data-driven, but there's a good way to go. I was actually thinking of renaming this last night, the futility of managing heart failure, but I've decided to be optimistic. So this is infographics I carefully carved myself. So heart failure affects 500,000 people in Canada. There's 50,000 new cases a year. The epidemiology of prevalence increases with age, so it's 1 in 10 of the very elderly. It still actually has a very poor prognosis attached to it, and even more recent data suggests that your median survival is about 50% at 5 years. And it's the cost. So the cost is extremely high. So this accounts for well over 1 million hospital days. The average length of stay is 11 days. That's a median. It is coming down slightly in BC. The rehospitalization rate, which we'll talk about a lot, is always about 20-ish%, 20, 21% at 30 days. And half of that is to do with repeat heart failure hospitalization, and then half of it is to do with other causes of hospitalization. So there's that dichotomy, the split, 50-50. And it accounts for a huge amount of healthcare expenditure. The official figure for Canada is $2.3 billion. I think we've seen cardiac services data suggesting that the total cost is about $1 billion just for BC. So it's obviously proportionally more. And this is the BC landscape. These are cardiac services slides, and what you see is that, I always find these slides interesting, that the actual crude incidence and the crude prevalence on the right in the pink is steadily increasing, and then the age-adjusted incidence and prevalence, there's a slight decrease in the incidence once you adjust for age, and a much less of a concerning increase in prevalence once it's age-adjusted, which would be absolutely wonderful if we could stop the population aging. But the realities of it are age-adjusted doesn't mean all that much in terms of this is the number of people that we actually need to treat. So it's gone from 66,000 up to 106,000 people there. the space of just over a decade. And for those of you interested in healthcare systems, the classical description of a lot of healthcare systems is that they're called machine bureaucracies. And that means that they develop from poorhouses where care was delivered in the very worst parts of suburban areas, and then they're very hierarchical, they're not very integrated, and we deliver care from a tertiary or secondary care perspective. And obviously that's a fairly predictable control model that we can put some boundaries around. But what's happened over the last 50 years is we have more and more treatments, and we've moved into a complex adaptive system, and I'll show you a diagram on the next slide. But that starts to get into theories of complexity, and it's the classical: a butterfly flaps its wings somewhere and some atoms move and you end up with a hurricane somewhere else. And a complex adaptive system is like that, in that you try and do one thing and you invariably actually cause something else which was entirely unanticipated or very difficult to control for. And I always put up this slide because I think it's important to remember the very basics of what we're supposed to be doing. So everything's always the same in these diagrams. So if you're a manager, you get taught on the classic iron triangle of costs and quality and access. If you're the WHO or the OECD, you have 3 E's. So you have equity, efficiency, and effectiveness. And sometimes people will say, actually, what we should really care about is equity and effectiveness, i.e. making people better. And the efficiency is just like an instrumental bit to get there. I mean, it's nice, but we just want to fix as many people as possible. That's our purpose in life. Especially if you're a taxpayer, you pay money into the healthcare system fixes you up. And then that also translates into the high triple aim as well. So this is a health system, and it's difficult to find diagrams of these, and I didn't want to construct a huge map based on a Canadian healthcare system. So this is a US, so you'll see there's some strange little nodes in the background. But you start to understand that when you think about what you're doing, you do something, but then that patient maybe doesn't have the right health coverage or the same insurance plan, or their deductible's slightly different, and then they don't take that medication, or they don't take the medication. I prescribe them apixaban twice a day, and they try and spread it out by taking it once a day, and then they have a stroke, and the stroke causes something else. So, systems just interplay with each other in ways that are unforeseen. But broadly speaking, you can think of any system as having inputs, and then some processes, and then an output and outcomes. And they're important to separate out, because I can say I want to increase the amount of ACE inhibitors, but that doesn't necessarily mean, or it might mean, that I'm going to improve hospitalizations or mortality. So we often use surrogate markers or process measures because we think they're linked to outcomes, because it's very difficult to say, well, we just want to reduce all-cause mortality in BC for heart failure, because that's a big fat goal to try and get hold of. And heart failure is the kind of prototype of a complex disease. So I've taken all the different acute heart failure registries here and looked at their comorbidities. And there's a general rule of thirds, which is there's risk factors of probably more than half or 2/3, but most of the comorbidities are at least a third. And this was probably a little while ago, and some of these registries, now you'd probably see that there's a greater increase in comorbidity, but a third of people have renal failure or diabetes or kidney disease. And it's the multimorbid population which is the challenge. So this was old data, but it's probably still the best, that shows that 40% of patients have more than 5 non-cardiac comorbidities. So when you're trying to treat hospitalization, it's not just that their heart function needs improved, it's all of the other complexity around it. And it's the multimorbid patients and population that account for the greatest proportion of so this 40% have 80% of the resource use. And we've seen from lots of studies now that it's not just that you have a comorbidity, it's the fact that the comorbidity has a bidirectional interaction with your heart function. So it doesn't really matter if it's cardiopulmonary syndrome or cardiorenal syndrome or cardio-blood syndrome with anemia. Whatever it is, having heart failure as a syndrome causes all sorts of systemic effects, and they worsen organ function, but then the worse organ function interplays with worse outcomes, but also sometimes with cardiac function as well. And hospitalization, which is what we'll talk about a lot, is an exceptionally complex beast. So Rahimi did a systematic review of this, and they identified 314 different predictors in different predictive models of the reasons for rehospitalization. And I kind of summarize these in this diagram, and you can see that they loosely bracket up in the center in sort of groups, so your heart function or your hemodynamics or rhythm or comorbidities or various other aspects. Then there's predictors on the middle ring, which are things that we often measure. And then there's the more acute things that we sometimes, if you have a baseline predictive model for outcomes, you won't necessarily know that somebody's going to not take their tablets or have too much salt and go out for that meal or take too much of a drug or develop acute sepsis, because that's a very difficult thing to predict. So there's precipitants and predictors, and they kind of overlap. The relevance of this is when you build predictive models, you see that, so for those of you less familiar with predictive models, we essentially measure part of how well they predict outcomes by something called the C statistic. So 0.5 is effectively, it doesn't work at all. That's the play of chance. And 1 is perfect prediction. And we're quite good at predicting mortality and survival. Like, we kind of know what kills people. So the C statistics there will be 0.7 up to 0.85 for some models. For heart failure hospitalization, it's much, much worse. So the C stats can be 0.6 to 0.7. And what that means is we don't really know why people are hospitalized. So if I was Donald Rumsfeld, I would say, on the right-hand side, these are the known knowns. So these are the things that we know definitely predict hospitalization. And it's always the same. So you can do these systematic reviews and you find lots of predictors, but it's age and gender and diabetes and renal function and heart disease and ejection fraction and the kind of common things. And then in the hash marks here, I've sort of said, well, this is the sort of known unknowns. These are the things that if I had a perfect data set, I would capture all of this. But I know that actually we just weren't able to measure it, but it does exist. I know it's a predictor, I just didn't capture it in this particular environment. And then the stripes, this is the unknown unknowns. So this is the stuff we just have no idea about. And for hospitalization, I suspect we don't understand it at all. And if we took in data from social media or Twitter feeds or your Facebook account, we'd probably find that we could work it out because you're suffering from more depression, or you've just tweeted that the lift's broken in your apartment block and therefore you can't get up the stairs, and your neighbor's dog has died, and therefore whatever it is that causes you to go and seek extra help, and if you can't get it from primary care, you come to a secondary care center. So that's the complexity of heart failure hospitalization. So that's what you're trying to deal with. And now we have complexity of treatment, because we have 7, arguably 8, therapies now that improve survival or reduce mortality and reduce hospitalizations in heart failure. We used to just have ACEs and beta blockers, and now we've got MRAs, spironolactone, eplerenone. We've got Entresto and ARNI. We have ivabradine, which reduces cardiovascular hospitalizations. We've got ICDs, CRTs. Ablation is debatable, but there's certainly a lot more evidence for ablation in heart failure, which someone's going to laugh at me in the audience for, but I think it's pointing that way. So if you're a health system, you have to deal with that complexity. Like, how are you going to reduce hospitalizations, which is costing $1 billion for us to the economy? And there's traditional ways of doing it. So we start by, we have guidelines, and then we build registries, and we audit what we do, and then we start to build in some performance, possibly incentives and some quality improvement around that. As the system advances, we have integrated decision support to try and guide us in these decisions and make sure that we don't forget things. And then we're moving with data towards an era of precision medicine, where things will be tailored towards the individual patient based on the data and the statistical models behind it. And I hear a lot about big data. In fact, that's all you ever hear about. And what I would say is that while we do have a big data problem, i.e. we don't have any, we have a tremendous little data problem, which is we also don't have any. So, unfortunately. And you can think of little data as structured data. So it's a specific variable, and you can capture it in different environments. So there's ambulatory care here in the green, there's hospital care, and then in the gray there's registries, which is sort of accumulations of this information used in a more static way. And it's important to understand that the features of these are absolutely not the same. So Cerner, CST, is not going to sort out magically, like clicking our fingers, all of our problems in the healthcare system, because it is a hospital record system. It deals with a single episode of care in time. It's for decision support in that acute condition. It interfaces internally to lab systems, and it's to do with order sets and referrals, and it has very complex documentation. But that's very different to longitudinal outpatient care, where often you have a very short diagnosis list, the data points are a little bit more simple, the documentation requirements are probably more simple, but you also have to pull in data from more disparate sources. And then registries can be longitudinal, or they're sort of longitudinal and events, and often based around procedures, but that's more population focused. So this is to try and look at the whole of care in a region, or BC. All of these will have structured data fields, and it's about how you structure those data fields and how you get them to interact. And by a data field, I mean heart failure. Like, heart failure itself is a pretty useless term because it doesn't tell you if you've got a low ejection fraction or what your treatment is or what type of heart failure it is. And then we apply it. There's different ways to structure it. So if I then set up a system where I have a back end and it codes into ICD-10, that's better. ICD-11, I've seen some insights to, which is almost transformational. I mean, it's very, very different to how you would perceive ICD-10 and all the preceding coding systems. So ICD-11 is going to be very, very different. What you want to do with data fields, though, is you want to standardize them. So you have to mean that a intolerance of an ACE inhibitor in Lionsgate is the same as intolerance of an ACE inhibitor in VGH when you're recording that information. So you have to have definitions, which we'll come on to, but you can look at these through CHI and the CCS. You also want it to be a sort of fixed value as well. So you want something that people can't be free texting, because yes, you can use machine learning to scrape data out of that free text, but it's certainly, you want a discrete data field. And then you can start to build in mandatory fields and logic, so that you're collecting this structured data in a very organized manner. And then on the far side, you have unstructured data, which can literally be anything. So this can be pulling information from natural language processing, or from free text putting into an EMR, or social media streams, or Twitter. And I've seen some pretty amazing things looking at that, but we're a long way from that in heart failure at the moment. Because when you come to clinic, this is now, in theory, all of the things that we should, and hopefully some of it we do, we have to think about it, and it has become quite complex. So we have to think about all of the medications that they're having and escalation to target doses, and that's 5 or 6 medications now. And then I always say to people, like, you're here for a drug or a box for devices or ablation, and then you've got your cardiovascular risk, and you're thinking about their coronary anatomy and what you can do to improve the blood supply to that myocardium, and then all of those comorbidities as well, which I suspect means we need to move to different models of care, which is going to address this, as we're getting more and more overlap between these therapies as well. So iron treatment in heart failure, or SGLT2 in heart failure. So who's going to prescribe that? Is it endocrine? Is it heart failure? There's heart failure trials of SGLT2 ongoing at the moment. So when that comes out, and I'm sure it'll be positive, where does that therapy sit? So these are the things we need to think about, and no human being can actually do this perfectly for every single patient who comes to clinic, or I certainly can't. So what you want to do is you want to build your EMR, your electronic medical records, to facilitate all of this and collect all of that information. But you also want to build your EMR so that it does all the other things that we're not currently doing. So we should be able to completely avoid any medication errors. And I met with Corinne Hull earlier in the week to discuss her ADE CIHR grant of trying to get the adverse drug reactions, which are now going to be reported through that system, into PharmaNet, and then pulled from PharmaNet into the EMR. So now we won't have patients being recurrently hospitalized or going to the ED because of drug interactions or things which were known and avoidable. We should be able to have decision support in there, build patient portals, send information to patients, and also on a mass scale actually look at how well we're doing. So it's not just about mortality and hospitalizations, but it's about the patient experience, so PREMs and PROMs, and we need to deploy those in some standardized way. So at the bottom there, you've got the Kansas City Cardiomyopathy Questionnaire, which is probably the best tool we have for heart failure. And that's something which ideally you would start to have patients completing when they come to the clinic on a tablet. So I've got a couple of slides of what we've been doing with our current EMR. We've been redesigning it a lot over the last 2 years. But just to give you a very simple example, you can see here that we have a create a care package, and you can click on medications or click on education and then send. And part of that send function, so this will take the Cardiac Services BC approved heart failure education resources, take those PDFs out, put it on the patient portal, either there for the patient to log in and access, or email to the patient. And we can do all of this within the EMR. And we can also structure things so we align with guidelines. So this is the CCS heart failure guidelines updated. And this is the risk classification of how often we should be seeing patients. So we can start to use the same amount of resource. We can see some patients more often, some patients less often, same number of visits, hopefully tailored to what the patient actually needs. So the question is, does all of this make any difference? And that is not entirely clear, I have to say. So the Swedes and the Scandinavians have led the way in most of these initiatives. So this is the Swede HF registry, and it has 21,000 patients in it with heart failure in the outpatient setting. And they compared it to the National Patient Registry of 230,000 people. So they have every single patient in Sweden in registries. And what you can see is if you're in a registry, at the top, your unadjusted risk of, this is survival, is that 0.65. So you are much less likely to die if you're in the Swede HF registry, which sounds great. But then when you adjust for the fact that these people are younger and have less comorbidities, you'll see that that adjusted risk actually changes. It's 0.82, the sort of middle grouping of things. And then when you adjust for the fact that they get the right medications, you're more likely to get the right medications if you're in the Swede HF registry because you're coming to a heart function clinic, then your adjusted risk is no different. I.e., there's nothing magical about data collection, and there's nothing magical about being in a registry, other than you do get the right therapies. You're more likely to get the right therapies. But the patient or the function of the registry itself doesn't change much. And one of probably the largest heart failure initiatives is to get with the guidelines, GWTG in the States. So that's got 630 hospitals. It's got 1.5 million hospitalizations. And you can see that from baseline, so this was just 2016, you can see that as these measures have been put in, these performance indicators, uptake of them all has improved. So these initiatives definitely improve, whether it be MRA uptake, which is one of the greatest improvements there from 20 to 40%, or are you going to get an ICD? You can see a dramatic increase there as well to getting your flu vaccine, which is very important in heart failure. But does it actually improve outcomes? And again, it's a little bit underwhelming. So now this, I would say, is the very early days of Get With the Guidelines. So they only had 4 process measures. Have you had your ejection fraction measured, ACE inhibitor, discharge instructions, and smoking? But what you see when you compare them to the non-Get With the Guidelines hospitals is that the unadjusted and then the unadjusted reduction in hospitalization is 0.5% by actually being a hospital which participates in Get With The guidelines, and when you adjust that for various hospital characteristics, it comes out about 0.3, 0.4%. And that's an important number to fix in your head, 0.3 to 0.4%. So Get With The guidelines has expanded. This is the current, I've just taken off the website. This is the current heart failure discharge, what should be measured in the US. So as you can see, it's got very, very extensive. And I'll show you this, and then I'll explain where this is coming from. So if you're a cyclist or a Team Sky follower, you'll know that Team Sky went from terrible to conquering the whole world in quite a short space of time. And they did this based on the theory of marginal gains, which is to say, when you have complexity and multifactorial systems, you need to chip away at all of the different causes of complexity. And they really did. So, I mean, they obviously redesigned the bikes and they changed their helmets to be more aerodynamic. But they actually go in and they vacuum like all the rooms for dust particles so that your bronchial reactivity will be different. They have their own beds on the team bus that they then load in and out of hotels. They paint everything in white so that dirt is picked up, so that any dirt on the bikes is going to be less. They have massage and diets, and they do hand washing relentlessly because they've realized that the amount of days you train per year, even if you have a cold, is actually very, very important to your overall team performance. And then they have metrics like you would not believe. And what you saw, that's a large part of the reason that Team Sky did so well. And obviously, you know, they do some dubious things with salbutamol inhalers as well. So yes, you can push your marginal gains a little bit too far, to be fair. But how is this relevant? Well, it's very relevant to heart failure and complexity in healthcare. So this is another, you know, the US, since the Affordable Care Act, has generated huge amounts of data. And you take 600 hospitals here, and they looked at strategies that are associated with lower admission rates. And then you look at the number of strategies that hospitals implemented. So any individual strategy reduces rehospitalization rates by about 0.2 to 0.35%, which is exactly what we saw in those other studies of the Get With The guidelines. But as you accumulate strategies, so once you get to 6 or 7 or 8, then their hospitalization rate's a bit higher to start with 25%. It comes down to 23%. So I sat in a meeting the other day where we were trying to set a target for what our rehospitalization rate should be. You know, and people wanted to set it, we're going to reduce hospitalizations from 20 to 10%. And I was like, well, that's better than any healthcare system in the world has ever achieved with every trillions of dollars. If you could reduce your rehospitalization rate by 2%, that would be a monumental achievement. And I'd suggest to you that in an aging population who you would expect to get worse, it would actually be an achievement if you held your hospitalization rate 10 years from now to be the same. But you'd only know that if you collected the right data and did the adjustment. So that's what you need to look at. And these are the individual hospitalization reductions based on all of the interventions. So if you have a transition plan, where is it? Blah, 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 blah. Follow-up appointments, 0.19%. A process to send all of the discharge information electronically, 0.21%. Do you assign staff to follow up directly on certain blood results? 0.26%. So you would have to do all of these things and collect all of this if you want to shift that needle on heart failure hospitalization. What Cerner will allow us to do, and this is a dashboard from one of the US hospitals, is it should be allow us to actually monitor performance in real time. So you'll be able to break out and say, is this hospital or is this unit? What are your rehospitalization rates? How many people are discharged on a beta blocker? How much of that is appropriate? Any metric that you actually want, you in theory, should be able to build dashboards for. So we've started this, I would say, at PHC. This is where it all started. And 2 years ago, or when I was a fellow, we started an audit where we took a paper audit and we kind of built it on a model of the UK National Heart Failure Audit. So we've standardized all the definitions. We've trained chart abstractors. We have a 50-page manual for the SOPs for the rules of the chart abstraction. We have a database and decision support built in SQL, which is a generic programming language. It connects to the hospital information system and the discharge abstract database and SCM. And then it pulls in different information with various interfaces. We've built a front end that makes sure that your data is captured perfectly, so there's no missing data at all, and it's all absolutely as you would expect because each field is carefully defined. And then we've been gradually sort of building this and expanding it out. So this is the front, and it doesn't look very nice, I'll admit, but it is highly effective because you can tab through very quickly. And so if I choose to say ACE inhibitor, no, then I have to choose why. Was it the patient declined, or is there a contraindication? And now if I choose contraindication, then I have to choose a reason with a specific definition, which then means we can compare rates across the board. And this is important, and this is an important slide, because prior to this, we were actually dedicating resources and having staff going to the wards and training and giving education about the importance of giving ACE inhibitors and beta blockers. And of course, what we were doing is we were taking all patients with heart failure for that. And our rates were 53% and 80%. But then when you looked at how many it was actually indicated in, with reduced ejection fraction, the middle bars, you can see that the appropriate use goes up. When you actually look at how many people had a genuine contraindication, defined by the CCS guidelines in a standardized way, you find that we're actually really, really good. In fact, I would say St. Paul's Hospital has the highest appropriate beta blocker prescribing rate in heart failure I have ever seen or heard reported by a long way, 96%. Like, you'll never see that. So it's utterly superb care, but we were pouring money into something which couldn't be improved. But there's lots of findings here which are relevant to the whole of the hospital and VCH in general. So we see fib or flutter in 2/3 of patients. Over half of them have anemia. Most of these patients were looked after in the medical wards. Our use of spironolactone was relatively poor. Appropriate use 59%, better than a lot of reports, but still 40% of patients who should have an aldosterone antagonist weren't getting an aldosterone antagonist. A fascinating observation that 1/5 of patients are discharged on no loop diuretic at all. Half of our ICD or device candidates were missed. So when we're looking at why our implant rates are very low compared to, say, the UK or the Netherlands, this is why. It's because we're not collecting the right data. And our use of all the transition tools was really suboptimal. So now you can start to actually collect this and say, right, this is where we're going to dedicate our QI to. And since then, these are my circles, which I keep adding to, but we took this to the VCH SSC-supported physician-led quality initiative. That happened last year. It's been connected up to the VCH central data resources, so the warehouse for labs, discharge abstract database, vital statistics. We've launched QI initiatives at both hospitals based on that data. It's becoming part of a regional cardiac program. We are starting our first year of chart abstraction at VGH because we've just had it all connected to the data systems finally after a year, where we're going to take 450 charts of the last fiscal year will be done in a couple of months. And now we'll have about 2,000 patients in this audit. So we can start to build a little bit more complex models because we have 100+ variables, all perfectly with that number of people. We've started the ball rolling to build this into Cerner so that hopefully when you press discharge, it will say, oh, actually, your kidney function is improved and now you're now eligible for an MRA and your potassium's okay. Do you want to prescribe this? Or, I note this patient is eligible for an ICD. Do you want to make a referral here? And in doing that, you actually make sure that far fewer patients fall through the cracks. And also, if it's felt not to be appropriate, it should be a drop-down so we can code up the specific reason at a regional level why you are not getting that therapy. Is it blood pressure too low? Is it physician reasons? You'll have seen Tech for Home as a provincial strategy for remote monitoring. And I think we're going to try and take some of that data and work in how we build it into advanced analytics in future. Provincial strategy is up there in orange. That means people might one day want to take this on at a broader level. We started having some discussions in PhD about looking at machine learning to try and improve our predictive characteristics using this data. And then we'll come on to pragmatic trials even later on. So if you looked at the interventions you can use from this data, because you can collect data, but you actually have to do something with it. And the Cochrane have this kind of taxonomy where they break it out into provider, organization, and system level kind of buckets. And then there's a systematic review, very recently been published in the BMJ. So it looks at 38 quality initiatives in heart failure. And what I would say is that these studies are a very mixed bunch of different designs, but often pre and post, which is not very resistant to bias, diverse interventions, underpowered, there's a narrative synthesis. There's lots of problems with this. But what's interesting is that most quality improvement initiatives transiently improve some process measure, i.e. I do something on the ward and it increases whatever it is. But actually, the provider level, education, reminders, single interventions have a fairly minimal effect in the systematic review. And that you have to have multifaceted organizational interventions, which will come as no surprise, than actually are the things that shift the needle the most. But even then, there's very limited impact on clinical outcomes long term. And that's exactly as you'd expect because of this complexity of heart failure and the heterogeneity and the need to chip away at all of those different aspects. And I've got a few slides about incentives because I think incentives are dangerous and complex and have many unintended consequences and very, very rarely do what they should do. So in the UK, we implemented the QOF, the Quality and Outcomes Framework in primary care. It's the largest pay-for-performance in the world. It expanded in quality indicators from a small to larger bundles for heart failure and asthma and diabetes and every condition. And it was related to income. So practices could boost their income by up to 25%. And we spent £10 billion on this. And there's been 2 studies out of Manchester University in recent years, one in the Lancet and the BMJ. They are very, very complex, but one called a longitudinal spatial study, where they basically find no relationship between performance and survival in heart failure specifically, and one where they do what they create a synthetic use case. So they take data from all around the world, and they build a population kind of similar to the UK in as many characteristics as they can match up, but which didn't have pay for performance, and then they compare the two. And yes, things improve, but things were improving anyway. And the pay for performance itself didn't really do an awful lot. And you see exactly the same thing. So this predated the Affordable Care Act. This was the Medicare Premier program, where certain hospitals enrolled. They were selected and invited to enroll in this program. And then there was incentives. So you got a 1% to 2% bonus or penalty, depending where you lay on the deciles. And you can see from 2003 to 2009, heart failure 30-day outcomes, there was no difference with incentives in these hospitals. Here's Ontario, so published last year, 8 million discharges, 31% of eligible patients were, this was about transitions of care. So primary care got a bonus on your MSP coding if you were seen within the 14 days. So it's to improve transitions of care. And what you see is that on the top left, everyone's very good. People claimed it a lot, but they didn't claim it. They kind of claimed it on just the people they were seeing anyway. You can then look at the rehospitalization rates, and you don't see any change or improvement in reduction in hospitalizations. No change in outcomes of any form, despite spending $17.5 million on that specific fee code that was supposed to improve transitions of care. And maybe even more concerningly, so this is a complex paper, but effectively they try and look at readmissions, actual readmissions compared to expected readmissions, and if you have an excess readmissions. And the issue is that excess readmissions are not necessarily related to excess survival. So in the States, there's been a huge drive to push down readmissions. But of course, sometimes people actually do need to come back to hospital because they need treating. And maybe it'll improve their outcomes if you do readmit them. So there's a close correlation between the penalties and readmission rates. There's actually an inverse relationship between penalties and mortality. So they incentivize different things, and readmissions and mortality go opposite directions. And since the Affordable Care Act was implemented in 2012, hospitalization rates have gone down, but actually, for the first time ever, adjusted mortality for heart failure in the States has been gently creeping up. So this is what I'm talking about in a complex adaptive system, how you have unintended consequences. And it may be that we just need to look at novel performance measures. So in the Scandinavian countries, they're starting to look at how you, instead of just saying tick you on an ACE inhibitor, tick you on 50% of an ACE inhibitor or 50% of a beta blocker. And that does relate to outcomes. So it's something we've started to look at in the PHC audit here, to look at what proportion of patients will go home on a reasonable amount, or 50% of the dose. So this is the infamous Affordable Care, High Quality Act, Tech Act, whatever it's called, for where we lie on electronic data systems. So any volunteers for where we lie at the moment? I'll put this to Jamie.
Somewhere in the gray.
Somewhere in the gray, yeah. Fragmented point solutions or an enterprise data warehouse currently in the making. And you can see we have an awful long way to go before we get to prescription, or personalized medicine and prescriptive analytics. And there's a lot of steps there, but you have to start to build on audit and do registries and collect data in your EMRs before you can get to that stage. So like I say, there's a transition. You go from retrospective to prospective. You start to look at benchmarking and performance. You build in decision rules. You have dashboards. And then as you get further down, you get into risk prediction and stratifying resource utilization. So you could imagine a system where you're about to press discharge and it says, this patient's risk of readmission is X%, very, very specifically. You need to be seen within 7 days. This patient's risk of readmission is much lower. You can be seen in 2 months, and you use the same resource to deliver better care. You can also look and then advise patients, so you can actually have genuine shared decision-making. You can explain to people whether they should have a defibrillator in an educated manner, and whether they should have palliative care, whether they should have consent for a procedure, which can be tailored. And Karen knows a lot about this in the coronary artery disease space in terms of informed decision-making. And although I've been a bit doom and gloom about data so far and the impacts of it, what I would say is that, for the geeks in the audience, this is a quote from The Matrix, that this is the sound of inevitability, because Moore's law suggests that the number of transistors in a dense circuit doubles every 2 years, and you can see it holds absolutely true. It's a straight line. So processing power increases no matter what, and quantum processing will arrive soon. The Internet of Things, so everything will have sensors, ubiquitous sensors, which will collect information about us. So yes, we're having TELUS for Tech for Home, but that's not how we're going to be collecting people's blood pressure or their heart rate. We're going to be collecting it through all of their different apps. And artificial intelligence. So this is a PubMed search for machine learning. And you can see in the last 2 years for heart failure, the amount of citations for machine learning, just off it goes. So the Google Developers Conference was last month, and I saw a Google Stanford initiative where they have 2 hospitals, 200,000 patients, 46 billion data points from their EMR. And then they take those 46 billion data points and predict death and length of stay and readmission. And that's the power of machine learning and artificial intelligence. So you can predict readmissions. You could use it to identify patients with heart failure who the ward or the staff might not know even have heart failure. You could predict incident heart failure in primary care. So you could take administrative data and you could push out messages to a primary care network and say, this is a flag for our annual review. This patient is at high risk of developing heart failure next year. You need to intensify their hypertension or their diabetes. You could predict, I've seen a paper here with artificial intelligence predicting adherence. So taking in social media and all sorts of data points about the patients to try and predict whether this person will adhere to their medical therapy. And then you could target education to those people who need it the most. And looking at phenotypes of heart failure and splitting it out into different groups that we just haven't really comprehended because we just use HFrEF and HFpEF, but it's far more complex than that. So I've told you that machine learning is amazing, but of course, Harlan Krumholz's group from Yale then get with the guidelines and they link it with Medicare, and they have 250 variables and a huge data set, and they compare lots of machine learning models of predicting hospitalization. And you remember I said that the C statistic was about 0.6? Well, it's 0.6 if you use generalized boosted models or lasso or regression or whatever type of machine learning you use. In this data set, there's actually no improvement over the standard CMS traditionally built model, which I think is interesting. So you've got to be careful with all of these studies that claim the machines are going to save the universe because they clearly need to be tested. I think it'll come in, or this will become very important because telehealth with the Internet of Things will also be relatively inevitable, and there's lots of drivers for that. So it will help access and efficiency and quality all around. And you can see all those different dimensions that telehealth is going to improve. We have tech for home, which is currently using relatively basic sensors. But what that gives us is a data set where we can start to look at that, combined with patient characteristics, to look at longitudinal modeling from physiology. And my final slide, so maybe and I'm not sure what the time point of this will be, but you will have the health system and data networks. You'll have remote sensors. You'll have the Internet of Things feeding information in. You'll have your social media being brought in. And then you'll have the traditional omics of proteomics, genomics, all of those omics built in as well. And then that's going to be the total systems medicine, which will probably involve trillions and trillions of data points. And you think, well, trillions of data points is outrageous, but it's not outrageous at all, because 46 billion data points was outrageous 5 years ago. So 1 trillion data points will, whole genome sequencing, it costs, a few $100s now. So proteomics, all of this stuff will come, and I think it'll all be integrated. The question is how we get there, where we start, and what the timeline is. It's not that it's going to happen, it's just when it'll happen. So hopefully I've convinced you that heart failure is very, very complex. There's no simple solutions, but if you're going to deal with complexity, you're going to end up with a form of total systems approach, which is going to largely be data-driven. There you go, 50 minutes. Perfect. Not one?
Hi. Oh. Here, your St. Paul's data that you have in terms of the heart failure information that you've gathered.
Yep.
Are you utilizing that in a way that it will help the medicine program change how we look after our heart failure patients?
So that is part of the reason I'm here today. So we've started slightly backwards in that from a regional cardiac program and regional heart failure program, there's an initiative started at VGH. We're effectively going to use the same platform, which has support and funding in place for quality improvement. And yes, we want to engage medicine here in the same way, because this is all through decision support. So it's not specifically a cardiology initiative. This was something I've been helping decision support with, and therefore it's all contained within decision support. I mean, I don't have access to that data in any way. it's housed with them. So I would be very keen to speak to people about how we go about that. Yeah.
Thank you for your talk. Just to follow up what Dr. McKay was saying around medicine, because we certainly live the multi-morbidity and the heart failure patients, because when we're on call, we are the ones who are seeing and admitting them. And I think a substantial proportion of those patients have multiple barriers, though, that they aren't really able to follow up in heart function clinics. So I think what the patients at cardiology are typically following have a lot of capability and skills and supports. And there's a whole bunch of patients that have so much comorbidity and multimorbidity and mental health and substance use disorders that I think can't benefit from therapies. So I think there is also potential for digital divide as we go forward to think about, and the whole socioeconomic situation that people are experiencing. So their care for multimorbidity, not just heart failure, all the chronic conditions, their life expectancy is dramatically shortened. So that's a gap that we struggle with in medicine. So we would obviously love to provide more guideline-based care, but sometimes it's very challenging in our patient population that come to the medicine program as inpatients and even as outpatients. So I just want to offer that as a context for this particular hospital that may be distinct from VGH.
Yeah, I mean, I think that's right. St. Paul's has certainly a fairly unique population from those barriers. What I would also say is that, we often see these papers saying, cardiology care is associated with better outcomes or whatever it may be, and I actually don't buy into that. I don't think there's anything magical about, seeing a cardiologist versus anybody else, to be honest. It's about the system of care and the structure around it, and we have discussions with CTU, with Shane and Ian and Laura at the moment for VGH in terms of how we stratify patients. And this weekend's job is partly to look at literature on how we decide who's most appropriate for the heart function clinic. And we certainly don't want to see, or we don't have capacity to see everybody in the heart function clinic. I would like to see a far more unified approach where medicine and cardiology are more integrated. We are, aside from this, moving to a single point of access through the SSC for heart function, where we will have the same EMR, the same wait list, the same everything across the 2 sites for heart function clinic, the same protocols, the same discharge. I think we also want to move to a situation where we are not retaining so many patients and we're discharging back to other care providers, particularly to reduce the burden of, say, access for patients to come from long distances just to come to a heart function clinic and repatriate back to, if from a Fraser Valley, for example. The multimorbidity question is difficult because how do you define what's multimorbid and more or less appropriate? I'm not sure there is a patient who's more or less appropriate for the heart function clinic, and a lot of the support we have in the heart function clinic is multidisciplinary. So it's the specialist nurses and the pharmacists who make that clinic what it is. And those resources obviously then need to be extended to other groups so that we have an approach like that, I think. Yeah. Health service comments? Data comments?
No questions. Good, great presentation. Absolutely excellent.
Okay, good.
So the deal is ECH finally connected all the ECH data and the style installation questions chart. But the next simple was sort of established previously that had sepsis discussed treated to certain effects. So they should do just get rolled over it because it's existing. Yes, it. It's like that's sort of consumption for voice. Yeah. It's like provide. Yeah. Like provide. The view. And what to have. That was great. Yeah, that was excellent. Why is it a dry subject? Oh yeah, they're really good. I'll just send you the slide there. I'll just give you the slide there. I'll share it.
Yeah, Jen and Tricia as well.
Hi. Nice. Also the liaison.
Jen is everything other than
This was the hardest support team. Now the project BA support. Project BA. Business analyst. Okay. I like it. I like your thing.
Especially cardiologists. These guys might be too young for me,
Yeah.
Yeah,
Who's that?
exactly. The A-Team. Do you ever know about the show The A-Team? Yes.
It's looking up when I was a child. I'm like, that's what it is.
Yeah, and I'm 25.
So it's younger. All right. Thanks for the. That's great.
Your call will be disconnected.